going to introduce all of the speakers at the beginning of the talk, and then they will go through their talk. Each has a part to present. As I mentioned, it's a whole team led by Dr. Ophir Klein. Dr. Klein is Chief of the Division of Medical Genetics and Medical Director of the Craniofacial Center. His research focuses on understanding how organs form in the embryo and how they regenerate in the adult, with a particular emphasis on the processes underlying craniofacial and dental development and renewal. And he's clinically interested in patients with tooth and skull anomalies. While doing his genetics residency at UCSF, Ophir became interested in craniofacial syndromes, and at the same time, as a postdoctoral fellow, he started to study dental and craniofacial development. He's then followed by Alice Goodwin. Dr. Alice Goodwin completed the DDS PhD program at UCSF. Her thesis work with her mentor, Dr. Ophir Klein, focused on understanding the role of RAS signaling in tooth development utilizing rasopathies as a model. She then finished a residency in the UCSF Orthodontic Division. She's now an assistant professor in the Department of Orofacial Sciences and cares for patients with the craniofacial team and in her practice at the UCSF Orthodontic Clinic, and runs her lab studying secondary palate and TMJ development utilizing mouse models. Next, Margaret Langham, also known as Peg, a pediatric nurse practitioner and coordinator on the craniofacial team, will talk about her part on the team. She fell into the craniofacial world when she needed a job. Working on an interdisciplinary team care intrigued her, and she was captivated by the kids and their families. She has been at UCSF for 10 years now. Then Dr. Jason Pomerantz will speak. He's an associate professor of surgery and the surgical director of the Craniofacial Center. He runs a basic science lab focused on understanding the molecular regulation of muscle stem cells. And last but not least, Dr. Glenn Rosenbluth, who I think many of you know. He's a pediatrician in the UCSF Craniofacial Center, as well as the Division of Pediatric Hospital Medicine. He has done a lot of work for our pediatric residency program over the years. I think he served as interim residency program director at least 3 times. But now he is mostly focused on systems-based practice within the UCSF health system, engaging residents and fellows in that work. And he has a clinical role within this team as well. And with that, I'll give it over to Dr. Klein.
Great, thank you, Sandrine. So we're really happy to be here. And today, Jason and I, who lead the team together, are really happy to have a number of our colleagues with us. And as you'll see in a minute, the team is actually quite large and has a number of different specialties as part of it. And so the reason we call this a reintroduction to the team is because many of you will be familiar with us. For some of you, this is new, but we also wanted to share some of the developments that have been happening in the field over the past few years. And I have a conflict, which is listed here. So what we're going to do today is explain the basic elements of cleft and craniofacial team care, and hope that at the end of this, you can understand the clinical findings and potential treatments in clefting and craniosynostosis disorders. So first, we'll introduce the team and the program, and then we'll go through evaluation and management of cleft lip and palate and craniosynostosis, and at the end, talk about a project that was recently completed about the transition to telehealth. So this is a picture from a few years ago from our team, and it's to give you a sense of how large it is, and I'll tell you in a second all the various disciplines that are represented within it. So at the center of everything that the team does is the child, the patient, and their family. And we have many, many different specialties that are represented in our team, including neuro-ophthalmology, neurosurgery, oral medicine, plastic surgery, prosthodontics, speech pathology, pediatric dentistry, genetics, and more recently, with Glenn joining us, pediatrics, ENT, orthodontics, social work, and audiology. And in parallel, we also have a very robust craniofacial research faculty, including many of the folks who are on this panel, as well as all the people listed on this slide. And this is a growing team. So we have our headquarters at Parnassus on HSE 15, but there are a number of labs both at Mission Bay and at Parnassus, as well as the General Hospital, who participate in the program, and we have a lot of activities. If there are any residents who are interested, we have weekly seminars or research in progress activities. So cleft lip and palate are among the most common craniofacial malformations. Birth defects in general occur in 1 out of every 30 live births and are the leading cause of infant mortality in the US, take up a large amount of the inpatient volume at most children's hospitals. And it turns out that many birth defect syndromes involve the craniofacial complex. It's probably the most affected part of the body in terms of birth defects. And this has, as we'll talk about today, enormous personal, social, medical, and economic consequences. Clefts of the lip and palate can be divided in a number of different ways. Cleft lip can be either complete or incomplete. And this is a cleft of the primary palate that's anterior to the incisive foramen. The secondary palate is posterior to it, including the soft palate. So a complete cleft palate includes both the primary and the secondary palate, and an incomplete is a cleft of the secondary palate only. From a genetic perspective, it's not as important whether the cleft is complete or incomplete, but what's more important in terms of inheritance is whether it is uni or bilateral. The incidence of cleft lip and palate and cleft palate only varies. In terms of cleft lip and palate, we see a very significant correlation with ancestry, where it's most common in Native Americans and Asians, less so in Caucasians and Hispanics, and then the least frequent are in people of African descent. Males are more often affected than females for reasons that we don't yet completely understand, although there are some hypotheses about this. And there's also a sidedness bias, again, which is not well understood, but there are some ideas about this, where the left side is more commonly affected than the right, which is more commonly affected than bilateral. And clefts are the rarest, and they often will go along with specific syndromes. Cleft palate only, which we tend to see a little bit more frequently with genetic syndromes than cleft lip and palate, is something that occurs in about 1 in 2,500 births. This, unlike cleft lip and palate, affects females more than males. And one idea around the sex bias here is that the palatal shelves fuse a little bit later in females, which may prolong the period of sensitivity to various insults. And at this point, I'm going to turn it over to Alice, who is going to talk about the development of the craniofacial complex.
Thanks, Sophia. If we could go back one slide. So the face develops from 5 facial primordia, the frontal nasal prominence, paired maxillary prominences, and paired mandibular prominences that are shown here on this SEM of a Carnegie stage 13 week 4 embryo, human embryo. And the names of these different processes are not as important as the main idea to take away, that these primordia give rise to all the features of the face, and disruption causes clefting. Next. Now I'll talk a little bit about lip and palate development in greater detail. So the lip develops during weeks 5 and 6, when the maxillary prominence fuses with the medial nasal prominence shown there. And the closure is complete by 7 to 8 weeks. And failure of growth or fusion of these prominences results in cleft lip with or without cleft of the primary palate or the premaxilla. Next. And the palate develops a bit later. One more click over here. At 6 to 9 weeks. And during this time, so here we're showing you cross sections of a human embryo, and the palatal shelves here, which are outgrowths of the maxillary prominences, develop vertically adjacent to the tongue. And then a little bit later, as the mandible grows downward and forward, the tongue depresses and the palatal shelves reorient horizontally and then grow towards one another and fuse in the middle. And the closure of the palate is then completed by 10 to 11 weeks. And failure of any of these processes, such as growth, elevation, or fusion, results in clefting of the secondary palate. So now I'm going to talk a bit about the work in my lab, understanding secondary palate development. And specifically, I'm going to talk about a project looking at hipposignaling in secondary palate development. And so just to introduce you to this pathway, hipposignaling regulates morphogenesis by controlling cellular processes such as proliferation, apoptosis, and differentiation. And it works by negatively regulating its downstream effectors, YAP and TAZ. And these are shown in this little diagram of the pathway. And the important thing is that YAP and TAZ go into the nucleus to induce transcription. And in the craniofacial region, YAP and TAZ have been shown to be important in neural crust, mandible, and tooth development. And interestingly, gain-of-function mutations of YAP have been reported in families with cleft lip and palate. So we're interested in studying YAP and TAZ in palate development, and we deleted these genes in the palatal shelf mesenchyme, and it resulted in a cleft. So as you can see here in our control, the palate is fused, and in this micro CT below, the bones of the secondary palate are fused. But when we delete YAP and TAZ with a call2 Cre driver, which is active in the posterior palatal shelf mesenchyme, you see a cleft, and the bones of the secondary palate, the maxilla and are not fused. The maxilla and palatine are not fused. And when we look at multiple time points, we find that loss of YAP and TAZ causes a palatal shelf elevation delay. So here I'll just orient you on these cross sections of the mouse embryo, coronal sections from the anterior, middle, and posterior, because morphogenesis varies from the anterior to posterior of the palate. So as you can see at E13.5, which is embryonic day 13 and about a 19-day gestation in mouse, the top shows the control. We see the palatal shelves developing vertically, and it looks similar in the mutant on the second row. However, a day later at E14.5, we see that while in the control, the palatal shelves have elevated, in the mutant, they're not elevated. They're still in the vertical position. And by E15.5, while the control, the palate is fusing, the palatal shelves in the mutant are just elevating. So it does appear to be this elevation delay causing clefting. We also wanted to see which genes YAP and TAZ are regulating during palatal shelf elevation. And so we performed an RNA-seq on palatal shelf tissue during the time of elevation. And we found that there were 22 significantly differentially expressed genes based on a false discovery rate of 0.05. Where the three most differentially expressed genes were these three marked with arrows: FEX, LOXL4, and IBSP. And so FEX and IBSP encode proteins important in mineralization, and LOXL4 encodes lysyl oxidase involved in collagen cross-linking. And I'll just show you in the next slide the expression pattern of IBSP and LOXL4, which you can see here in red. And you can see IBSP is expressed in kind of this superior medial portion of the palatal shelf mesenchyme, and it's decreased in the mutant. And we did find indeed that and again, this gene is involved in mineralization, and we did find that the volume of the bones of the secondary palate were decreased in our mutant. And furthermore, this LOXL4 expression LOXL4 is expressed in a similar region, and this region is thought to be this hinge region around which the palatal shelves elevate. And so we're very interested in the role of this region, which is not well understood at this point, in elevation, and also how collagen cross-linking could be generating intrinsic force to actually lift the palatal shelves. And so to conclude, we found that YAP and TAZ play a dual role in secondary palatogenesis in both palatal shelf elevation and mineralization of the bones of the palate. And now Peg will talk about the first year in the lives of our patients with cleft lip and palate.
Peg, you're still muted.
Okay, good. Let me just start again then. So in transitioning to the clinical role, so my role is to explain at least part of what was just explained to you in much more simple terms to the families, explain to them what to expect from the surgery and most surgeries, and most importantly to explain that we have an interdisciplinary team to help support them. Parents, I usually meet parents either in the prenatal period where they've had a ultrasound diagnosis of cleft lip and palate, or immediately after they're born. And in any case, they're in crisis. Their head is full of everything they've heard, people have told them. And so my role is to calm them down a little bit, help them sort all of this out, and explain to them that the complete care will be it will revolve around having this this very kind of ordered progression of care that will involve lots of different providers, but that they can relax, that we will kind of take them through that. And so for me, I decided to focus on the first year because a lot happens, and a lot happens that involves me in the first year. So the very, I'm going to go through feeding. I'm going to talk about the pre-surgical treatment of the cleft, briefly about the surgeries, and then at the end, I'm going to talk just briefly for a minute about Robin sequence. Next slide. So just to give you an idea of what we're talking about here, these are not newborns, but they're pictures where you can easily see on the first one, you've got a unilateral cleft lip and palate, a complete cleft lip and palate with the nares as well involved, and it's almost moved over to the side. It's a very typical look. And then on the other side, a baby with a cleft lip, I'm sorry, with a bilateral cleft lip and palate, where it's really not, that central section, thank you, is not attached to really anything except the bottom of the nose. So I'll come back to this in a minute, but first I want to talk about feeding. So now next slide. So the issue with feeding is that if the palate is cleft in the back, then the muscles aren't together and you can't create suction. So if you can't create suction, then you can't breastfeed, and you can't use a regular bottle. So we have these special bottles. This is the Dr. Brown, the blue one, where you put a one-way valve into the nipple. The milk goes into the nipple and doesn't flow back because of the one-way valve. The baby's then able to chew on it, the milk, and use their tongue. The milk falls to the back of their tongue, and then they swallow. Normal kids with cleft lip and palate or cleft palate only have no swallowing issues. And so as soon as you get it to the throat, they can swallow. It's not an issue. The other bottle is a Haberman, which we don't use as much, but I just thought I'd show. Next slide. And so just to show that this is, once we get the bottle going, really, the babies can eat really well, really easily, normally. Anybody can feed them. This is a very kind of comfortable, easy way to feed. Next slide. So back to these guys again. So the next part of my role, and actually involves the orthodontist and the surgeon, as well as figuring out what we're going to do to kind of do some pre-surgical treatment for this cleft lip and palate to bring the gum lines and the soft tissue closer together. So in the case of, so we use lip taping to do that. And so you can see that's it's just Duoderm on the cheeks and a Steri-Strip, and we're bringing everything together by way of using some of the maternal hormones that are still floating around that make everything very malleable, and get actually a lot of movement, especially on the unilaterals. The bilaterals can be a little bit more challenging, although this one's in a good situation, but we're trying on the bilaterals to bring that segment into the middle and have the gum into the dental arch. And so we often will use NAM with that. Next slide. And so this is the picture that's before and after, is actually before and during. This is a orthodontic appliance where the orthodontist makes a mold out of a customized mold, creates the NAM, and then the NAM is adjusted week by week to very precisely bring those segments together. And then at the end, we use that nasal piece to begin to shape the nose as well. We use this also on bilaterals. It's perhaps arguably more important on the bilaterals, where you can really line up that segment that we saw before that wasn't aligned with anything. And then this is to get ready for the surgery. And they walk into surgery with a lip taping on or with a NAM in, and then it gets taken out at surgery and they never have to do it again. So it's the first part of life. They feed well with these. And then let's go to the next slide. So, so here I'm going to bring in the cleft palate because the surgery, the path is very similar from after the closure of the lip. So this is a nice picture of a cleft palate. You do, obviously this is made, this diagnosis should be made shortly after birth, typically not made prenatally. You owe your patients, in my opinion, one good look inside their mouth with a good light source and maybe a tongue depressor to move the palate out of, to move the tongue out of the way so that you can really see the palate. I sometimes feel them before I see them, but that you want to be sure it's not there. This is, the palate clefts can be bigger than this or smaller than this, but this is kind of a typical look. Next slide. These kids also have the same, they use the same bottle as the kids with the cleft lip and palate because the issue with the cleft palate of not having the muscles together is the same. I pay a lot of attention to the feeding and the appropriate weight gain. We use one of these feeders. These kids tend, the kids with cleft palate only often seem to have more nasal regurgitation than the other kids, and not the kids with cleft lip and palate, not quite sure why. But the big issue they have, and I again see this more in the kids with cleft palates than cleft lip and palate, is very prolonged feeding times where they're taking 2 ounces of feed, but it takes an hour to get in. So I'll really work on consolidating that because we really want them to gain good weight to get ready for surgery. The other issues in the first year related to cleft palate are speech, although comes in more towards the second half of the first year, ears because they're prone to chronic serous otitis media, which is why part of why we have OH&S on our team, genetics for reasons that were delineated earlier. And then the palate surgery comes around 10 to 11 months, and that's kind of the end of the first year for them. So I'm gonna, next slide, talk quickly about Robin sequence. So this is the has the 4 components to it: the micrognathia, glossoptosis, cleft palate, and airway obstruction. So because the jaw is small, the tongue hangs back, and particularly if there's a cleft palate, they don't always have cleft palates. The palate, the tongue will, the bottom, the base of the tongue or the whole tongue will go into kind of rest in the cleft, and it really creates some significant airway obstruction on the part of the tongue base. And so next slide. This is, so there you can see how far back the tongue is, and right, yep, and it towards, you can't really appreciate the palate, the cleft palate, but it's back there. And then this other picture on the other side is just a very typical look for kids with Robin sequence because you can see the small jaw, and there's also this very worried look that they have because they can't breathe. So even in this sort of well-supported position. Next slide. So the focus in taking care of these kids is to sort out the airway. And so if you are, so the kind of first line intervention can be, if the kid is really having trouble while you breathing and you haven't quite sorted anything out, is to put them prone. That drops the tongue out of the airway and often can make for easier breathing while you figure out what you're going to do next. Obviously they can't go home in either prone or side lying, but we can manage them while we figure out how we are going to manage it. And this includes a pretty good airway workup. We want to be sure that the tongue base is the full cause of the airway obstruction, that the rest of the anatomy is normal. Often genetics will be involved because, as was mentioned earlier, this is more common. It's cleft palate, and then Robin sequence is more commonly involved in a genetic syndrome. We want some sort of sleep study or some kind of delineation so we really understand what the pattern of obstruction is. And so, but then going down from the to the airway, the tongue lip adhesion is something we used to do more often. It sort of fell out of favor. It's a little bit more in favor again, but it's basically, it is what it sounds like. You take the tongue and adhere it, not to the lip, but below the lip, and move that tongue just out of the airway. The more common operation these days is the neonatal mandibular distraction. And so for a kid where we've established that the tongue base really is the cause of the obstruction, and you can use the distraction surgery to get the tongue out of the airway, it's a wonderful operation in terms of how successful it is. You go from this baby who can't breathe and therefore can't eat to over a few weeks to a baby who looks normal, breathes normally. They usually start eating normally, and it's lovely. All by way of trying to avoid a tracheostomy, which is sort of the last line. The feeding, once you could get them breathing, we can usually get them feeding pretty quickly with a cleft palate feeder. They do need close follow-up as part of their craniofacial care, as ongoing airway management. And I'm gonna, do I have one more slide? I'm sorry. I do. So now that 1 year now we've gotten them through the first year, and then all the other teams, members become in some ways more important, and we continue to need, very closely coordinated team care. And I'm finished now. We give away. These are. I'm happy to talk about these. So you've got a unilateral incomplete cleft lip. You got it? Okay. Sorry, I'm still talking.
No, that's okay. Go back one up here. Thanks. So as I think everyone has mentioned so far, there's a large variation in cleft lip. These are all images of babies with cleft lip, unilateral and bilateral. On the going from the top left to the bottom right is from the, you could say from the least to the most severe deformity. On the top left is a baby with an incomplete cleft lip, and then there are two babies with complete cleft lip and palate, one on the right and one on the left. They can be narrow or wide. The two in the middle are relatively narrow, and the one all the way on the right is a wide unilateral. So these are all variations of the same deformity. And as Ophir mentioned before, that's genetically unimportant, but surgically makes a difference in terms of our technique. On the bottom are babies with bilateral cleft lip, again ranging in severity. On the left is a baby with a complete cleft lip, but you can't see in the photo, but an intact alveolus, so intact primary and secondary palate, and minimal nasal deformity. And right next to that is a baby with a complete bilateral cleft lip and palate. And that segment that's in the middle sticking out that Meg was talking about earlier is called the premaxilla. That's the primary palate, which is completely disjointed from the secondary palate. And the primary palate is where the four top incisors come from. And that lump of tissue on top of it is the prolabium. It's skin and connective tissue, but it has no muscle in it. There are asymmetric variations. The third from the left is a baby with an asymmetric bilateral. And then on the right is a older, it's a toddler with complete bilateral cleft lip and palate. And the point of that one is, as Peg mentioned, we like to repair cleft lip at about 3 to 4 months of age by convention. And part of that reason is that, as she showed, there's a lot we can do to pre-surgically mold the tissues, and that means really move the bone segments into the right position. And that's very difficult to do after early infancy. And so the baby or the toddler on the lower right requires an additional surgical procedure where we actually have to fracture the septum behind the premaxilla and move it into position. And that has negative effects on how the face grows later. But there's no way to close the lip over that. Whereas in a young infant, like the second from the left, we can use nasoalveolar molding. That's basically the retainer type device that Peg showed, to move that premaxilla into a better position, which is more favorable. It doesn't just make the operation easier, but it results in a better outcome for the baby. Next slide. So these are examples of a unilateral cleft lip. This baby on the upper left has a complete unilateral cleft lip and palate, and ideally at 3 to 4 months of age, although it can be done later. The baby undergoes surgical repair, which is done under general anesthesia. The baby's asleep there, intubated under anesthesia. In our institution and in most institutions, this is a single overnight stay, primarily for comfort and training for how to care for the wound. The babies feed normally immediately after surgery when they wake up. So normally meaning how they were feeding before. If there's a cleft palate, their feeding situation hasn't changed from what Peg described at this point, because they don't have that, the hard or the soft palate repaired. So they can return right away to breastfeeding if they don't have a cleft palate, or feeding with an assisted device if there's a cleft palate. And the operation generally takes about 2 to 3 hours. On the lower left is from a surgical standpoint, the deformity. You can see the orbicularis oris muscle is not in continuity in a cleft, and the fibers on the lateral side go up into the nose. And there's always a nasal deformity associated with any cleft lip. It can be from minor to severe. This is a typical cleft nasal deformity. And the operation of the lip repair is done in layers. It involves the skin. It involves reorienting and repairing that orbicularis muscle, the gingiva underneath. And then we also repair the communication between the vestibule just above the lip and the nose. So that's a fistula repair, which is done with tissue from inside the nose, and that makes it so the baby and then the child doesn't have to deal with a nasolabial fistula until age 8 or 9, when it would otherwise repair. Goals of cleft lip repair are really we're aiming for essentially normal appearance by school age, and in about 15% of cases, a revision of the lip repair is required to tidy up the scar or to address another aspect. But in the majority of cases, the single operation is adequate for achieving normal appearance by school age. The kids go home after one night stay, and our postoperative pain regimen now is Tylenol and Motrin for a cleft lip repair. Complications are generally minor, unfavorable scarring, and infection is quite rare, and we consider it a complication if we need to do a revision. Major complications are exceedingly rare nowadays with cleft lip repair. Next slide. Similarly, bilateral cleft lip, the saying used to be it's twice as difficult and the results are half as good. But with modern techniques for lip repair, the appearance is quite good. These babies and then children typically need early surgery on the nose to improve the appearance, which is done before kindergarten. But it's a similar timing of surgery, 3 to 4 months of age, 1 overnight stay. And what we're able to do with the premaxilla pre-operatively, so this is where we really rely on the early introduction to our clinic and on the orthodontist. What we're able to do with the premaxilla and whether we can put it into position before surgery really dictates the outcome. So that's why that pre-surgical nasoalveolar molding is very important, and the orthodontists play a huge role in that. So moving on to cleft palate. As Peg mentioned, a cleft palate repair is typically done before a year of age. In our hands, 10 to 12 months. It's a single stage operation. We really want to repair the palate by 15 months at the latest. And the reasons for delay are comorbidities or airway concerns typically, or late presentation. If palate repair is delayed beyond that in years, there's a increasing delay or inability eventually to achieve normal velopharyngeal function. And the goal of palate repair is for normal speech. So we're aiming for normal appearance with the cleft lip and nose repair, and we're aiming for normal speech with cleft palate repair. The second goal is to minimize regurgitation of food and liquids into the nose, which becomes irritating over time. We work closely with our otolaryngology colleagues for timing and setting up the palate repair. Typically, there's eustachian tube dysfunction in the majority of babies with cleft palate. And so at the time of palate repair, the otolaryngologists are generally performing a EUA and myringotomy and tubes in the majority of cases. These photos show the spectrum of palates that we repair. On the top left is a submucous cleft palate. The most minimal variant of that is a bifid uvula, which by itself is not a functionally important finding. I think 10% of the population has a bifid uvula, and that does not signify a velopharyngeal dysfunction. But this baby has a submucous cleft palate, and what that means is that the soft palate muscles are not aligned properly, and the baby will ultimately, and the child will ultimately present with velopharyngeal dysfunction manifested by either regurgitation, but primarily by speech abnormalities. And the easy way that we use to make this diagnosis is by palpation. At the posterior aspect of the hard palate, there should be a bump. That's the posterior nasal spine. And if there's a notch on palpation, then you can make the diagnosis of submucous cleft palate, and there's greater likelihood that will have a speech implication later. The goal of palate or the surgical technique for palate repair is to reorient the soft palate muscles. That zigzag shown in the upper middle is the plan to do that. Here's the baby under general anesthesia, and the tissue is elevated, the muscles are dissected out and then reoriented in a zigzag fashion. It's called a Z-plasty or furlough procedure. And on the bottom is a baby with a complete cleft palate. And you could see most easily there the hard palate is what you're looking at, and the soft palate is in the shadow posteriorly. The nose is up on the top of the picture there. And in a complete cleft palate, we're elevating that tissue, which is marked out off of the bone. And then the nasal lining is turned over, and then that tissue that you can see is brought together in the middle to repair the defect in 2 layers. And separately, we have to repair the muscles, and that's done similarly to what's shown in the upper photos. So this is also an overnight stay, and Tylenol and Motrin, and we also use oxycodone for pain control. 85% of babies who have non-syndromic clefts are able to obtain normal speech, meaning no velopharyngeal dysfunction detectable by a speech pathologist, and 15% have some residual velopharyngeal dysfunction and require a second operation on occasion if that affects their intelligibility in general. Complications are also uncommon. Dehiscence or fistula formation is the main complication, and that is occurring in about 2% of cases in our hands. I went a little quickly there, but we're picking up the pace a bit to make up some time. I'm going to turn it over to Glenn Rosenbluth now. Thank you.
Thanks very much. And yeah, so I'm going to switch gears a little bit from talking about the palate or the clefting of the lip and palate to a bit about the head shape and skull. And I just want to briefly say, well, I'll go into this. So just anatomically, just a reminder that the skull is made up of 7 different bones: the paired frontals, the paired parietals, the paired temporals, and the occipital bone. And then on the next slide, just a reminder of the suture language, that the metopic suture runs down between the paired frontal bones, and we have the left and right coronal sutures, the sagittal suture running longitudinally, and the lambdoid. These are the 4 most common ones that we're dealing with in the clinic. And just a reminder, every time 2 bones come together, that's a suture, and then where multiple sutures come together, we get the anterior and posterior fontanelles. On the next slide, just a reminder of how we think about assessing skull shape. And I do want to say, in our program, Eve Rorison, who's the fantastic nurse practitioner, does a tremendous amount of the initial assessments of babies who get referred to us with concerns about skull shape. So you'll certainly see her name coming up if patients come in for skull shape questions. But we always try to take a good frontal view, looking for symmetry of the position of the eyes, as well as the forehead. On the posterior view, in the bottom left, we're looking at the angle of the skull base. If the angle is not level, that could be a sign of craniosynostosis. That actually helps differentiate from positional plagiocephaly. Looking at the ear on the posterior view, ear position, are they level? Are they symmetric to each other? And then the potential of a mastoid bulge behind the ear would be a cause for concern. And then from that bird's eye view, the top right, probably the one we're most familiar with when looking for deformational plagiocephaly versus craniosynostosis. We're looking for symmetry. We're looking at the ear position. You can't really see in this baby the ear positions, but looking for whether one ear is anteriorly displaced. We always talk about the fontanelle, and Michael Cunningham in one of his articles calls it the pediatrician's handshake. I think every pediatrician likes to touch the fontanelle. It's really not that important for skull assessment as long as the shape is normal and the head circumference is normal. If you can't feel the fontanelle, that's less important. So then just briefly talking about deformational plagiocephaly, keeping in mind this is an extrinsic cause of skull differences. Normally the skull requires the brain to grow, and changes in skull shape that are intrinsic are due to early fusion of the bones. Modifiable risk factors for deformational plagiocephaly being mostly position, and then about 20% of kids will have with deformational plagiocephaly will have a congenital torticollis. And then there are some non-modifiable risk factors as well. There is some literature describing that deformational plagiocephaly is more common in kids with hypotonia and developmental delay. And in unpacking the literature, there's a lot of discussion about cause versus effect. And the consensus is that it's more that kids who are hypotonic or developmentally delayed are less likely to turn their head a little bit less, rather than the reverse. There's not a literature to support that deformational plagiocephaly in any way causes developmental delay for kids. So the management of deformational plagiocephaly, there are some great guidelines put out by the Congress of Neurologic Surgeons, which the AAP endorses, and they go through the role of positioning, physical therapy, and helmeting. What I'll say is there's definitely some discussion, even among our group, about the role of putting a little rolled up blanket pinned to the baby's shoulder to help position the baby off that side. I come down more on the side of trying positioning, like flipping the baby foot to head in the crib so that they're looking in the opposite direction to see the parent, or feeding them from the opposite side, rather than putting positioning blankets or things under the shoulder. What we definitely all agree is no pillows, no objects that would help position the baby. But certainly as babies get a little bit older, the risk of SIDS gets lower, even with side sleeping. So something you always want to talk about with your patients when describing risks and benefits of any treatment. The concerning things are not deformational plagiocephaly, but rather single craniosynostosis, of which we see briefly about single suture craniosynostosis. I've just put up a diagram, which also reminds me to say in the September issue of Pediatrics, there's really a nice article about assessing head shape in babies, but any of the sutures can be fused and cause some classic atypical head shape patterns. So then just on the next slide, these are just some examples, and I'll let you try to guess looking, because I'm not there with you in person, which sort of babies have which single suture craniosynostosis. This wasn't meant to be a focus on that, but if you want to cheat from the answer key, again, I pulled these images from a great article in the current issue of Pediatrics. You can go to the next one. So evaluation and management, what should I do next? And this is really, what do? We are happy to take these referrals if you have any concerns about a baby's head shape. And certainly there are some measurements like a cranial index, getting a sense of the width relative to the length, as well as head circumference. There's some data out there on using ultrasound, but our center and communicating with our radiologists, we tend to do CT scans, but we actually CT a relatively small number of kids, and it's really only the ones that have a confident diagnosis of craniosynostosis. Certainly Eve and the surgeons in our clinic, and I'm getting a lot better as a general pediatrician at picking out which ones are definitively craniosynostosis, but that's a very common referral to our program. In thinking about the causes of syndromic craniosynostosis or single suture, I'll just briefly mention there are a lot of genes that have been identified as implicated, but the FGF receptors and the twist signaling pathways are among the most common causes, but we could have put up a very long list. It's about 20% of single suture craniosynostosis that has some genetic association or genetic cause. And then finally, just what is my role in the clinic? Because people ask me all the time, is what I do is I really help make sure that the kids are getting all the care they need. Just as a hospitalist, I serve as a navigator in a lot of ways. In this clinic, I'm not anyone's PCP, though maybe I aspire to be someday. But I really help make sure the kids stay on the right timeline with all the different specialists. If you just want to show the next click, these are all the different specialists who may be involved in the care of a kid with craniosynostosis throughout the first part of their life, and certainly many more than that. So I'm now going to transition it back to Dr. Pomeranth to talk through some of the surgical management.
Okay, so these are more photos of babies with single suture craniosynostosis. Left is, I'll give you the, oop, my video's off. Can you hear me?
Yes.
Yes, we can hear
Okay.
you.
Left is a baby with unilateral coronal, middle is metopic, and right is lambdoid. That's a great lambdoid synostosis photo because we're really looking for the tilt in the skull base. You see the ears are vertically asymmetric there, and that's a real giveaway for the diagnosis. Next slide. The indications for surgery and the goals are threefold. The prevention of neurodevelopmental problems, meaning intracranial pressure and brain growth, normalization of head shape and facial growth, and for the anterior synostosis, protection of the eye, the globe. And we're really working closely with our neurosurgical colleagues to determine the timing of surgery and the technique. And the two techniques of treatment of craniosynostosis are an umbrella term, cranial vault remodeling, where we reshape the size and configuration of the bones of the skull, or strip craniectomy and helmet. Strip craniectomy means just removing the bone around the fused suture, and that's followed by helmet therapy, because we're not changing the shape or size of the skull with the operation. We're relieving the impediment and then relying on the rapid brain growth that occurs very early in life to mold the skull, and we use a helmet to assist that. And that's why presentation and referral to the clinic early is desirable for us, because we can offer that operation for babies who are younger than 4 months of age. It really doesn't work after that. And there's a moderately strong level 2 evidence and general consensus for using strip craniectomy for sagittal craniosynostosis only, and there's not data yet to support the other types. This is the procedure for cranial vault remodeling. We use that zigzag incision, it's a coronal incision over the top of the head. It's a zigzag because when hair grows in, it falls over the scar better and is more difficult to see. It's an invisible scar generally in kids with longer hair, and is generally visible with very short haircuts. On the right is our images of the cranial. Now go back, please. On the right are images of cranial vault remodeling. We're actually taking advantage of the very malleable bones of an infant. This is done at 6 months of age or 7 months for this procedure, reshaping the bones. And on the bottom right, you can see the completed procedure. It's remarkable how if done in the first year of life, these bones rapidly heal, the spaces rapidly fill with bone, and no helmeting is required postoperatively or even bulky dressings. Next slide. And with cranial vault remodeling, the procedure is done at the end of the operation. This operation takes about 4 hours. Babies stay in the ICU for 1 or 2 nights. By 2 weeks postoperative, they're acting their usual selves. Pain control is none or Tylenol at this point, and the head shape is generally complete. Next slide. Strip craniectomy is the other option. This is done through smaller incisions. This is babies facing down on the operating room table. You can see where we've shaved where the incisions will be, and the surgeon. This operation is done primarily by the neurosurgeon, and the bone is removed, and then the skull shape is not changed. The baby goes into a helmet for 3 to 9 months afterwards. And this is an option for sagittal synostosis, and we are using it or doing a trial now for babies with metopic synostosis, where the results also seem to be good, but not for coronal. Next slide. And the goal with single suture craniosynostosis treatment is a normal appearance and normal neurodevelopmental function. The data is quite inconclusive about whether and how much surgery for single suture craniosynostosis actually affects neurodevelopment. And we don't have time to go into that in detail. The only intracranial pressure data that we have is from a study done at Great Ormond Street, where an invasive pressure monitor was placed in infants before surgery. And for sagittal craniosynostosis, about 1/3 of infants have elevated intracranial pressure preoperatively. How high pressure needs to be to cause neurodevelopmental difficulties, as far as I know, not known. But the appearance alone, hang on a second, the appearance alone is adequate rationale for treatment of single suture synostosis. I have a couple of examples of syndromic synostosis, so everyone can gain a little familiarity with the appearance of some of the syndromic cases. This is a child with Cruzon syndrome, and we think of Cruzon syndrome as a normal face in an abnormal position. The face is generally structurally normal in its dimensions, except there's lack of anterior projection of the face, and this causes airway obstruction. Cruzon syndrome can have craniosynostosis, although it doesn't need to, and this is treated with, in this case, mid-face advancement, click, and another click, and that can result in normal appearance and resolution of sleep apnea and normal occlusion. Next click. Next slide. Apert syndrome is an abnormal face in an abnormal position, and typically always has craniosynostosis. This is I'm showing this example so that to make the point of the importance of ongoing evaluation and ongoing management. This baby came to us at the age in the previous photo, having had one cranial vault procedure early in infancy, and she presented with elevated intracranial pressure. You can see here on the CT scan, looks like the brain is trying to fight its way out of the skull. There's scalloping on the right of the bone, which is being thinned. There's no extra-axial fluid, and you can't see the ventricles. Next slide. She underwent an urgent cranial vault expansion, which relieved her intracranial pressure. She also required a VP shunt, but she already had papilledema at that point. So it's because she was lost to care for a number of years. We see these kids at least yearly, if not more, in our clinic. Next slide. And then in Apert syndrome, the midface and airway obstruction are dealt with next. You can see she has a tracheostomy because of her airway obstruction, and we work together with the otolaryngologist to determine airway interventions, and also the pulmonologists to determine likelihood of being able to remove the tracheostomy with mid-face advancement. Here it's done by this distraction procedure. Next slide. And ultimately she was decannulated. Next slide. And so still an abnormal appearance, but effectively treated, but really requires interdisciplinary management and your slide. This is just to illustrate our current approach to multiple suture craniosynostosis. This is a baby with a FGFR3 Muncke syndrome. Has you can see the tall shape of the head, pterocephaly, and also the tightness around the orbits. Next slide. The baby has craniosynostosis of both coronal sutures. And next slide. The right lambdoid suture. And next slide. In babies like this, we undergo an early procedure at about 4 months, which is posterior cranial vault distraction. Those are devices placed on the bone without removing it, just making a cut in the bone. Next slide. The bone is advanced posteriorly. You can see from the left to the right, creating space for the brain. The bone fills in over months. You can see it's completely healed here by 7 or 8 months of age. Next slide. Next slide. And then the baby undergoes a cranial vault operation at a year of age. Next slide. Next slide. And the result is essentially a normal appearance, normal head shape, and we've, with or without a shunt, depending on the typical, depending on the individual child, we can control intracranial pressure together with the neurosurgery team and result in normal appearance. Next slide, and Glenn.
So I just briefly going to show this graph of our experience with telehealth at Ryan Battier, who's a medical student, led this great analysis for us, just showing in the dark blue pre-COVID and in the light blue COVID, post-COVID, just showing how our recovery has been. This is only through June, and I certainly welcome you to look up the reference. And on the next slide, just our patient experience, green being good, and basically what we found is patients were quite satisfied with the experience, but they still prefer, it's a minority who prefer video visits to in-person, that small green amount and larger red. And so just to finish on some common referrals and consults, things we're happy to see in the craniofacial program: head shapes concerns, cleft lips, and palates. Again, bifid uvula can have submucous cleft palate. Any abnormal dentition, ectodermal dysplasia, 22q11 syndrome, even if they don't have an obvious cleft palate. We see a lot of those kids. And then Eve Rorison, our nurse practitioner, has a great growing practice of doing ear molding with newborn infants. So we thank you very much for your time and your engagement, and a huge thank you to the many, many, many other members of the craniofacial team who weren't able to present together with us.
Thank you so much, Glenn, and everybody else on this team for an outstanding presentation. It is exactly 1 o'clock. I do not want to keep people longer that need to move on with the rest of their date. So thank you, Dave. So thank you so much for joining us. There is one question from the audience in the Q&A, and that's about what gestational age are cleft lip and palate diagnosed in utero, and is in utero genetic testing set?
Yeah, so you can find cleft lip starting around, I think, the 13th or 14th week.
But it's usually
Sorry, go ahead.
it's usually the 20-week ultrasound. My referrals, the kids they're all like right around 20 weeks. That's the most reliable. I've seen it at 16. I've seen it missed till later, but 20 is kind of the typical.
Thanks. Yeah, and then the question about testing, so that often will trigger by the prenatal geneticist testing, depending on what else they find.
Great. Thank you so much. We're going to end it here. I really appreciate you presenting here, and we'll look forward to seeing you with a reintroduction maybe in a couple of years when there's, I'm sure, new inventions and additions to the team. Thank you so much and have a good day, everyone.
Thanks for having me.
Thank you.